Hi, good evening and salam sejahtera, ladies and gentlemen. Welcome to the live webinar Allergic Rhinitis, Are We Managing Optimally? My name is Lam, a ENT specialist in University Kebangsaan Malaysia Medical Center, Kuala Lumpur. This webinar is organized by the Department of Otorhinolaryngology Head and Neck Surgery, Faculty of Medicine, University Kebangsaan Malaysia. And the sponsor for this event is Mylan Healthcare. Ladies and gentlemen, allergic rhinitis is one of the commonest chief complaints among patients presented to primary healthcare and ENT specialist clinic. It is not difficult to diagnose allergic rhinitis, but can be challenging to control the symptoms and progression. We are delighted today to have with us two esteemed speakers to share their knowledge and experience in managing allergic rhinitis. Before we start, here are a few things to take note for all the participants. Please type your question in the Q&A box instead of the chat box. The speakers will answer your question at the end of the session. And CPD points will be awarded to all participants. The QR code will be displayed again at the end if you missed it at the beginning of the session. Please scan it with your MMA mobile app. To start the session, I would like to invite Professor Salina binti Hussein to deliver her welcoming speech. Professor Salina is a senior consultant rhinologist and skull-base surgeon and the current head of the Department of Otorhinolaryngology and Head and Neck Surgery in UKMMC. With that, please welcome Professor Salina.
Thank you very much, Mr. Lam. So, Assalamualaikum and good evening. First of all, I would like to thank Prof. Razif, Prof. Muhammad Razif, as President of Malaysian Society of Otorhinolaryngology, and Mr. Lam Saiguan. They are the organizing committee for this meeting today. So thank you very much. And I would like to express my deepest gratitude to our two expert panels, Professor Baharuddin Abdullah and Associate Professor Dr. Aniza Khairia binti Wan Hamizan. And we know that allergic rhinitis is basically a common disease, and it is not a fatal disease. But to treat allergic rhinitis is very important, and treat it optimally is the best treatment for the patient. So we know that allergic rhinitis, if we just live like that, it can progress to chronic rhinosinusitis, acute rhinosinusitis. That progression can lead to a fatal end. So basically, I don't want to talk more about allergic rhinitis because we have two expert panels. So they will talk, they will update you and give a lot of knowledge on latest treatment for allergic rhinitis. And I hope all the participants will gather all this knowledge from them and use in your normal practice. With that, I thank you.
Thank you, Professor Salina. Next, I would like to introduce the moderator for this webinar, Professor Muhammad Razif Muhammad Yunus. He is a senior consultant otorhinolaryngologist and head and neck surgeon, subspecialized in head and neck oncology surgery. He is the current president for Malaysian Society of Otorhinolaryngology and Head and Neck Surgery, and also the president for the Asian Society of the Head and Neck Oncology. With that, I welcome Professor Razif to moderate the session.
Thank you very much, Mr. Lam. Thank you very much, Prof. Salina, for your kind speech, blessing our program. So it's good to have a head of department bless our program. Thank you, Prof. Salina. Thank you, Mr. Lam. Mr. Lam has been helping us a lot in terms of organizing the program. So again, as mentioned, today we are going to have a webinar to talk on allergic rhinitis. It's a common disease as mentioned. And again, we are very happy to have two experts in their field of allergic rhinitis, Prof. Madia, Dr. Aniza, and also Prof. Baha. So first, we're going to have a first talk by Professor Madia, Dr. Aniza. I would like to take this opportunity to introduce the rising star in ENT fraternity, Associate Professor Dr. Aniza Kariah Wan Hamizat. She is a clinical lecturer and specialist in otolaryngology, head and neck surgery in our department, University Kebangsaan Malaysia. Her research interest is in the nose and parsal sinuses, inflammatory disease, and local and allergic rhinitis. The big point for her is she obtained her PhD at the University of New South Wales, Australia in November 2018, under the supervision of Professor Richard Harvey, who is a well-known rhinologist, and Professor William Sewell, who is a clinical immunologist. She's a truly, I must say, a bright and brilliant otolaryngologist, and we're very happy to have Prof. Aniza with us, sharing her knowledge on allergic rhinitis. So without further ado, I would like to welcome Prof. Aniza to give a talk.
Thank you very much, Prof. Razif, for the very, very kind introduction. Thank you also to the organizing committee, Mr. Lam, for inviting me here today. I'm definitely very happy to be here today to share what I know about allergic rhinitis. So if it's okay, I will share my slide. All right. Okay, can everybody see my slide? Okay, good. So I'll start my talk. Prof. Razif approached me to talk about allergic rhinitis. I actually wanted to talk about the things which I researched during my time as a PhD. And most of it was on the clinical characteristics of allergic rhinitis. And I feel like our students, our GPs, sometimes we are overlooking this fact and probably relying too much on the standard allergy test. So for the talk today, I'll just start off with just briefly telling you all what is allergic rhinitis, because I know most of you already know what is allergic rhinitis. Then I'll go on to talk about the clinical characteristics of AR. And then I'll go briefly about the management of AR. But I think most of you will probably be more interested in what to do when you see patients with poorly controlled nasal symptoms despite giving them intranasal steroids. So what is allergic rhinitis? It's very simple, really. It's just an inflammation of your nasal cavity. But this inflammation, when you talk about allergic rhinitis, is due to exposure to allergen. And this is an IgE-mediated type of hypersensitivity. And if most of you remember the types of hypersensitivity, type 1 hypersensitivity is the immediate type. And this would almost certainly lead to nasal symptoms, the commonest, the cardinal symptoms being sneezing, nose block, runny nose, and itchy nose. And I'd like to say that we should look for at least 2 or more nasal symptoms to diagnose allergic rhinitis. And these symptoms are generally reversible with medications or spontaneously. And it tends to last on more than 1 hour on most days. And when you have patients who complains of rhinitis symptoms, you can confirm that IgE-mediated inflammation by doing allergy tests. And the allergy test that we have is the skin prick test, serum-specific IgE, and also a nasal allergen provocation test. However, allergic rhinitis is a diagnosis of, it's a clinical diagnosis. And so we should focus more on the clinical history. So these are the characteristics of allergic rhinitis. Allergic rhinitis patients tends to be younger. They tend to be young patients, teenagers, children, people in their 20s. However, if you see patients who are a bit older, maybe in their 30s or 40s, you should ask about the onset of symptoms, because their symptoms are actually longer and they've had it for a longer time, but only now they are seeing you. Another thing about AR is that they tend to have more sneezing and itchiness. They can also tell you what are their triggers, because this is type 1 hypersensitivity. AR patients also tend to have more allergic comorbidities such as asthma, eczema, and conjunctivitis. So I would like to show you the studies to prove these allergic characteristics. Now, in this prevalence study done in the UK, it shows the lifetime prevalence of allergic rhinitis. You can see that it starts at about toddler age, and it peaks at about 15 to 19 years old. And as these patients get older, the onset of allergic rhinitis tends to be reduced. When you compare this to the non-allergic rhinitis patients, you will find that when we do a logistic regression, the older you are at the age of diagnosis, the more likely it is that you don't have allergic rhinitis. You have instead what we call a non-allergic rhinitis. And in a study by Brand et al., they have shown that if you are diagnosed to have rhinitis after the age of 35, it's more likely that it is non-allergic in origin rather than allergic rhinitis. And in these kind of patients, you should really look for all those non-allergic triggers such as drugs, hormones, or anatomical problems. So what to do if you see patients in their middle age now coming to you complaining of rhinitis symptoms? Well, the simplest thing is just to ask them when did they start to get it. And in this study which we did, we found that among non-allergic rhinitis patients aged about 50 years old, they will tell us that their symptoms are actually quite recent and started less than 6 years ago, compared to allergic rhinitis patients who will tell you that they've had the symptoms for quite some time. Okay. Another thing about AR patients is that among the 4 cardinal symptoms, we find that the sneezing and the itchiness is actually more suggestive of allergic rhinitis rather than non-allergic rhinitis. So if you look here, if a patient with rhinitis complains of sneezing and nasal itchiness, they are actually 4 times more likely to be allergic rhinitis compared to non-allergic. And if we compare the symptoms between AR and NAR, more patients, significantly more patients with AR will complain of that itching and sneezing. But if you look at rhinorrhea and nasal congestion, it is equal on both sides for AR and NAR. And we think that if you see a patient coming in with rhinitis and their chief complaint is rhinorrhea and nasal congestion only, not much of sneezing and itchiness, I think you should think that maybe this patient does not have allergic pathology as the cause of their nasal symptoms. Right. Another thing about patients with AR, which I think we mostly forget to ask, is that we have to ask them about their triggers. The easiest thing to ask for is pets, because those who have cats, they will tell you, I just can't be around cats. Whenever I'm around cats, I'll start sneezing and I'll have itchiness. Dust is a bit more difficult to ask, but you can still ask them, do they feel like they have, their symptoms are triggered when they are in dusty areas? And in this study, they found that patients who report nasal symptoms on exposure to allergen, they are much more likely to have a positive SPT compared to those who don't. And we confirmed this with our own study, which showed that if the patient complained of having symptoms around dusty area, more patients, they are more likely to be AR. Okay. And this is also another thing that we also know. Whenever you see a patient with AR, you must ask about the other allergic comorbidities, because if they have asthma and eczema, they are more likely to have allergic rhinitis. And if they have conjunctivitis, in this separate study by Di Lorenzo, patients who complain of concomitant allergic conjunctivitis are 4 times more likely to have allergic rhinitis. That means their nasal inflammation is IgE mediated as compared to those who don't. So in summary, these are what we have seen so far, which I think makes a pretty good prediction of whether you are really seeing patients who have true allergic rhinitis. But if you're still doubting your diagnosis, you can always do an allergy test to confirm it. So what are the allergy tests that we have here? We have the standard skin prick test, which is available in UKM, as most of you know. And we also have the serum specific IgE. Now, what these 2 tests does is that for skin prick test, you will apply the allergen on your arm and look for a wheel reaction. While for a serum specific IgE, you simply take the blood and you look for presence of IgE in the circulation. And these tests are what we call systemic allergy tests. Unfortunately, it tests for IgE in the skin and in the blood, but you are having your symptoms in your nose. So we also have these tests called nasal allergen provocation test. So instead of giving the allergen onto your skin, we apply the allergen directly into the nose and we look for a nasal reaction. And this is actually the gold standard for allergic rhinitis, not for allergy itself, but for allergic rhinitis. Okay, how about another test then? Instead of taking blood and sending it for serum specific IgE, you can also swab or brush the nasal cavity and look for specific IgEs in them. And this is what I did when I was doing my PhD. Basically, we used a cytology brush and we brushed inside the nasal cavity, and we put that in a solution and basically sent it off to the lab to look for the specific IgEs in them, similar to what we do with the blood. Okay. Unfortunately, the local tests are not widely available. We have nasal allergen provocation tests in UKM, but for the nasal specific IgE, it is mostly under research. And so for now, the standard of care is still that systemic test. Okay, the problem with this systemic test, as I said before, you are testing distant from the site where the allergy is happening. And so just to prove a point, we did a systematic review. We looked at all studies who took patients who have allergic rhinitis. And these patients were diagnosed to have allergic rhinitis based on symptoms and have either a positive skin prick test or serum-specific IgE. So it seems that it's pretty good, you know, it's a quite good diagnosis. And all these studies, they then did the gold standard, which is the nasal allergen provocation test. So among all of these studies that had allergic rhinitis, when nasal allergen provocation test was done on them, a pool summary of about 86% will then respond to the allergen when sprayed inside the nose. That means about 20% is not responding to the allergen. So it's not as good as we think. Now, on the flip side, we took all patients, all studies that looked at patients who had non-allergic rhinitis, which was diagnosed either by a negative skin prick test or serum-specific IgE. Okay, and when we put the summary together, we found that actually 26% still do react to the allergen when sprayed in the nose. So again, you can't rely solely on your skin prick test or serum-specific IgE to diagnose your allergic rhinitis. It is a clinical diagnosis. Now, we then put our theory to the test, where we took all the clinical characteristics which we think are associated with allergic rhinitis. Then we did another systematic review. We took all studies of patients who have non-allergic rhinitis. Then we divided them into 4 groups. So one group is those patients who have non-allergic rhinitis diagnosed by one standard test. So either a skin prick test or serum-specific IgE was negative, or studies that really made sure that they do not have allergic rhinitis, where they actually did both skin prick tests and serum-specific IgE, and they confirmed that both tests were negative. Okay, among that group, we then split it into either the patients having these allergic characteristics, which are allergic comorbidities, or patients were able to identify the allergens, or if they said they don't have these allergic characteristics. So if you look here, among patients that had truly, they really tried to rule out systemic allergy by having both SPT and serum-specific IgE negative, but with rhinitis symptoms. When we did a provocation test, 20% still reacted to allergen. So even though you have both tests negative, it still doesn't mean that they are not allergic rhinitis patients. They are still reacting to the allergens inside the nose. And these patients are what we call as local allergic rhinitis patients. But if you were to look at the studies where they had both tests being negative and they did not have any allergic characteristics, you can be very sure that you are not dealing with allergic rhinitis patients. So taken together, allergic rhinitis is a clinical diagnosis, and you should look for suggestive clinical features. You must not rely on your standard skin prick test and serum-specific IgE only. It is only to confirm presence of IgE among these patients. And it is only important to do a standard allergy test if your diagnosis is in doubt, or if you want to start immunotherapy for them, because at this stage, you must be very sure what are their allergens. Okay. You should consider local nasal tests for patients who have allergic characteristics, but have positive, meaning they have allergic characteristics of rhinitis. They have characteristics of allergy in their rhinitis, but their skin prick test or serum-specific IgE is negative. So these are the patients that you need to do local nasal tests, such as the nasal allergen provocation test, to rule out local allergic rhinitis. Sorry. Okay, that concludes the first part of the lecture. We'll now go on to the management of AR. We all know that whenever you see patients with AR, you have to counsel them. And this part is actually very important because you have to manage patient expectations. Some of them think that the drug we are giving will cure them. You have to tell them, no, it is only to control your nasal symptoms. And it is likely that you will need these medications for a long time. And you must counsel them to try and avoid whatever allergen that they think they're allergic to. Okay, but saying that allergen avoidance is easier said than done. We can generally prescribe them either a non-sedating antihistamine for those with mild or intermittent allergic rhinitis, or for those with moderate to severe disease or persistent allergic rhinitis, the first line should be a second generation intranasal steroids. And we have things like Nasonex and Avamys available here in UKM. And the thing about allergic rhinitis patients is that they will respond well to steroids. So this was from a study which I did earlier, some years back. We gave nasal steroids to all patients with allergic rhinitis. And after about 1 month, they will have significant rhinitis symptoms improvement. And the effect actually will start at about the first week. But after 1 month, that symptom improvement will just plateau. Okay, but after giving the intranasal steroids, you come back and you see them back at about 1 or 2 months later. What happens if they still say that their symptoms are just not getting any better? They say that's like less than 10% improvement. By definition, poorly controlled allergic rhinitis is defined as patients having a visual analog score of more than 5. That means if you ask them overall how bad are the symptoms, rated from 0 to 10, they will give a score of more than 5 despite using the nasal steroid. And this may happen in about 20% of AR patients. So note here, more than about 80% will still respond to nasal steroid. Okay, if this happens, you must ask yourself 3 questions. Are you really having a correct diagnosis? Okay, you may need to consider other diagnoses, and you probably need to consider that maybe they're not AR, they may be an AR. Okay, is your therapy correct? And then, of course, you must look into their compliance and technique. So when they are complaining that their symptoms are just not getting any better with nasal steroid, you need to consider some other diagnosis. You need to make sure that they don't have any bad septal deviation that may be preventing the medication from getting through, or the septal deviation itself is causing that symptoms. Or possibly one thing that we've always forget to look at is look at that nasal valve area. They may be having nasal valve dysfunction, which is the sole cause of their nose block and not rhinitis. In children, you need to think of adenoid hypertrophy. And if the children is really very young, under 3, I think you should first consider that maybe they have an undiagnosed choanal atresia, which can lead to nose block and rhinorrhea. Okay, so in adults, if your nasal spray is really not working, and especially if the patients have unilateral rhinorrhea, you need to consider CSF leak. Okay, so if you've ruled out all that, then you ask yourself, am I giving a correct therapy for these patients with allergic rhinitis? You should look into the environment. You know, if they can't really avoid the environment, the allergens in the environment, you can actually prescribe them some saline rinses, and this has been proven effective because it can wash out the allergens, wash out all the inflammatory mediators. You should also try and treat the most bothersome symptoms that the patient has. So this is when you start adding on your treatment. If they have, if rhinorrhea is the thing that's bothering them most, you can actually try intranasal antihistamine, which is azolastine. We don't have pure azolastine in Malaysia, but we do have it in the form of Dymista, where it is called, where you saw the advert, the slides earlier. It's a combination of nasal steroid and azolastine, so you can try that. Or another thing that's recommended is the ipratropium bromide, but and ipratropium bromide is very good at drying up your nasal secretions. Unfortunately, we don't have it here in Malaysia. So if itchy nose and eyes is their most predominant symptoms, then the antihistamines should work. And you can even give mast cell stabilizers eye drop like Opticrop into for the eye. If they say that actually the nose block is the one that's just most bothersome and they still have other rhinitis symptoms, I always recommend trying Clarinase or Telfasti, which is an oral decongestant. And this usually gives patients a more rapid relief, and you can give it to them short term. Now, how about if the patients have predominant nose block despite medications? Now, in this case, if the other symptoms are relatively well controlled, but the nose block is the only thing that's bothering them, those are your candidates for surgery. And this is something that Prof. Baha will talk about later. Okay, so now for the third question is, you must ask yourself, is the patient compliant to the treatment? Compliance is a big issue in allergic rhinitis, and you must always talk to your patients about being compliant to the treatment. And you must also check the technique. Unfortunately, a lot of our allergic rhinitis patients will only use their nasal steroid when they have symptoms. The minute their symptoms get better, they will forget. So this is something that you need to talk about with them. To be honest, if for my patients who have had long-term AR and they are quite stable, they don't have much complications, you know, I tell them to step down. And if they feel like their symptoms have returned, they can actually restart their medications again. So if you've asked yourself, oh, okay, sorry. And you must also manage patient expectations and tell them that you're going to need this nasal steroids for a long time. But for those patients who really want a better symptom relief and they want a long-term relief, they don't want to use medications too regularly, you can consider immunotherapy for them. Okay, so if all are correct, you ask yourself these three questions, and you know, you say, I'm definitely sure that this patient is an allergic rhinitis patient. Then you may be dealing with an allergic rhinitis patients who have one of the severe phenotypes. And the patients who tend to have severe AR are those who live in an environment with a high allergen load. There's maybe a lot of pollution around them, and they may be exposed to a lot of cigarette smoke. But another thing which we tend to forget about these AR patients is that they could have a predominant neuroinflammatory mechanism, and this is termed as nasal hyperreactivity. Now, nasal hyperreactivity is not the same as reacting to an allergen. In allergic rhinitis generally, the allergen enters your nose, and then your IgEs will then cause mast cell degranulation, you'll get the histamine, and you'll get your allergic inflammation. But in nasal hyperreactivity, there are triggers in the environment, which may be chemical or physical triggers that is just triggering your nerve endings in your nose, leading to symptoms. And this is actually a normal physiological response. But in some patients, it is hyperactive. And this is previously thought to be the diagnostic feature of vasomotor rhinitis, which is a subtype of non-allergic rhinitis. Another word for it is idiopathic rhinitis. The triggers can be either chemical, like cigarette smoke, fragrances, or cleaning agents. So they will tell you, I just can't be around perfume. You know, whenever I put on perfume, I'll be sneezing all day. Okay, it's really bad. Or they'll tell you that I just cannot be in a cold room. I can't stand it. My nose will start to block, and then I'll just be runny all day. And these triggers, these irritants are thought to trigger the sensory nerve endings, and the channels most popularly involved and most researched is the TRPA1 and the TRPV channels. Okay, please note that this nasal hyperreactivity, we found out that it is not a diagnostic feature of non-allergic rhinitis. It is equally present in both non-allergic rhinitis and allergic rhinitis patients. But what some studies have found also that among AR patients that have this nasal hyperreactivity, once you start them on nasal steroid, the nasal hyperreactivity will also get better, but not in all patients. In some of them where that nasal hyperreactivity is predominant, they may not respond as well to the nasal steroid. And this is something that we often do not address in our allergic rhinitis patients. So what can we do for them? Well, Azelastine has been found to be effective for nasal hyperreactivity. There are actually quite a few other treatment options such as capsaicin, which some of you may have heard of, but it's not available in Malaysia. What we do have is Azelastine, and Azelastine has been found to be effective in vasomotor rhinitis patients. Nobody is very sure on how Azelastine is having effect on the nasal hypersensitivity, but a recent study reported that it may desensitize that TRPV1 channel through the modulation of calcium. And so I really do feel that if we use the combination of steroid and Azelastine, we are also able to address this nasal hyperreactivity among patients with poorly controlled AR. And so the management of AR for me in my clinic is that I will usually start with the standard first-line therapy. And if they come back after 1 or 2 months, still complaining of persistent symptoms, totally not improving, I will then reassess the patients and treat according to the most bothersome symptoms. And at this point, I will consider giving them intranasal steroids and azelastrine, which is Dymista. Or if the source of the symptoms is actually high allergen exposure and they just can't avoid that allergen, these are the patients that you should consider for immunotherapy. Unfortunately, even though we do have immunotherapy, it still is expensive. It's about 500 ringgit per month for the tablet form. And for the sublingual form, I think it's about 700 ringgit for 3 months. And they have to take this for 3 years. And again, compliance is an issue with immunotherapy. But I will not talk more immunotherapy. This is something I think Prof. Salina is more of an expert on. And also, if you feel that the nose block is the most predominant symptoms, then definitely refer them to the ENT for assessment of possible surgery. So in conclusion, it is important to recognize the clinical features of AR, as it is a clinical diagnosis and you only confirm that IgE-mediated inflammation with your allergy test. But it is not necessary to do your standard allergy test to diagnose AR. You should reassess patients who do not respond to intranasal steroids because you may be missing some other pathologies, and try to treat according to the symptoms, because at this moment, what we have is only treatment for symptom control, and there is currently no cure for AR. For Dymista, which we have here in Malaysia, you can actually consider it early. If your patients want a fast symptom relief, you can give it early on for the first 2 weeks, then switch to your intranasal steroids. Or if they fail the intranasal steroid and have a predominant nasal hyperreactivity, you can ask them to switch to Dymista. Thank you.
Thank you very much, Prof. Andiza. You managed to make allergic rhinitis lecture interesting.
I'm so glad. Thank you.
Yeah, usually, yeah, it is make very nice, and we do have a few questions in which, if I can go through later on after Prof. Baha lecture, we can answer that question in live session. Before I move on to Prof. Baha, again, I would like to welcome all the participants. According to our organizer, we have registered 369 participants. At the moment, we can say about 260 plus already. So thank you again. Thank you very much. And we know that there's a lot of medical students here. We have our medical officers, our trainee registrars. We have even oral and maxillofacial surgeon join us today. Thank you, Hazme, for joining us. Thank you very much to our colleague in general practice. Thank you very much for joining us. We have ENT surgeons. I can see a lot of names. Prof. Baha, our friends, Datuk Patawari, Prof. Rahmat there, and Prof. Zol from UM, a few others. And also I would like to welcome, I see on the list, our President-elect MSO, Dr. Ahmad Nordin in Sabah. And we also see some participants from Indonesia. Again, welcome to our webinar. So ladies and gentlemen, not forgetting, thank you very much to Mylan, Dymista, for sponsoring this. Again, as we discussed previously, COVID, the good thing about COVID is that all this teaching session is free. So everyone can join. Prof. Baha, betul So that's happy. So it's a great pleasure for me to go to the next speaker, my good friends, Professor Dr. Bahrin Abdullah. Even though he is well known to us, but I still need to say something about him. He is a senior consultant rhinologist and skull-base surgeon from School of Medical Sciences, University of Science Malaysia. He is currently the president-elect for Malaysian Society of Allergy and Immunology, or MASAI. Betul Prof. Baha?
Right.
He held a number of professional posts at the national level over the years. He had published and presented in many scientific papers, both at national and international level. So when I look at the CV, it's very long list of publication. And Prof. Baha also actively involved in the services to many international professional communities as invited speaker and presenter. Again, it's our honor to have Prof. Baha to present his lecture today. So Prof. Baha, the floor is yours. Thank you.
Thank you so much, Prof. Razif. Let me share my slide first, then we go from there. Right, Assalamualaikum, good evening, ladies and gentlemen. First and foremost, I would like to say thank you very much and my sincere gratitude to the organizing committee, especially Professor Dr. Mak Razif, as the president of National Society ORL, and also Mr. Lam for organizing this wonderful webinar together with Mailan and with the full support of Professor Dr. Salina. Indeed, you have a great team there in University Kebangsaan Malaysia. As everybody is well aware, and has been mentioned previously by Prof. Salina, Prof. Razif, Prof. Aniza, allergic rhinitis is a medical condition. Allergic rhinitis, sometimes we take it as very simple, straightforward, but I think probably that is also our pitfalls. You know, sometimes we take it for granted that it's not going to kill the patient. So then we don't have to really put it into proper perspective in terms of how we approach our patient. Actually, in fact, I know that some of patients that has not been treated well, they really suffer. They really suffer because of the symptoms that affect them and because of the complications that happen and that come with it. So with that, the symptoms and complications, it does actually affect their quality of life. So having this webinar probably will put things in proper perspective. Even though I am actually going to talk about endoscopic nasal surgery or surgery in general, what to do for patients with allergic rhinitis, I'm not actually advocating surgery as the first line. I'm actually what I'm trying to highlight here is actually what can we do besides having medical treatment for our patient. For those who need surgery, what are the alternatives? What are the options available for us? So that is the proper way, and I think the proper sequence of the sequence of perspective that we should actually consider. I saw some familiar names in the among the list of the participants. I would like to say warm greetings to them. Indeed, actually, I not that in favor of having a webinar. I always prefer a physical meeting, and then I can see you face to face. But then again, no choice because of the situation that we are in now. Nevertheless, it's really a pleasure to be among my friends and colleagues. So the question now is, because we know that allergic rhinitis is a medical condition, and whether you like it or not, we have to accept the fact that pharmacotherapy is the mainstay of treatment. Prof. Aniza has already highlighted what are the available options in terms of the medical treatment, but I can say this for sure that most of our patients will be treated with oral non-sedating oral antihistamine together with intranasal corticosteroid. That should be the main stay of treatment for most of our patients with allergic rhinitis. So when we talk about surgery, and this sort of question that may come to us and may be posed by our patient, what about surgery? Can really surgery replace pharmacotherapy? And then we also should consider and actually, think what surgery can add to the improvement in terms of the outcome besides having pharmacotherapy being administered to our patient. If you want to look further into how we can fit in surgery in the algorithm, how we approach our patient with allergic rhinitis, this is an area long time ago, but still I would say one of the best way for us to consider in terms of treating our patient with allergic rhinitis. First, diagnosis must be properly established, and that there are intermittent symptoms. There are, intermittent allergic rhinitis, persistent allergic rhinitis, and then depending on the severity, we can divide that into mild, moderate, and severe. Those moderate and severe, their activities will be affected. And I can tell you for sure that most of our patients in Malaysia is having persistent allergic rhinitis, whereby they have symptoms throughout the year. It's not based on the season. And those patients with mild allergic rhinitis, they don't come to the hospital because of the, also that it's going to be a hassle for them if they come to the hospital to wait for the doctors, to wait for the medication, especially if they go to the public hospital. And so what they do is they go to the pharmacist, self-medication. Those who come to the hospital, definitely they are moderate and severe, with moderate and severe allergic rhinitis. And this is the algorithm. When we talk about moderate and severe, it is actually been recommended that this type of group of patients, we should start that immediately on combined treatment with oral antihistamine and as well as intranasal corticosteroids, so that they can be properly treated, and also we can get the fast relief for them. And from the patient perspective, it's always to get and obtain a fast symptomatic relief. But sometimes we never consider that that is the first and foremost importance for them to get that kind of relief. So then when we start them on anything that is actually inferior, they don't get any relief, and then that is where they don't want to actually comply with our medication. I totally agree with what Prof. Aniza mentioned about counseling and whatnot. I think it must be stressed from the beginning that compliance is always the utmost important. And from what I see, why patients don't improve is because of the poor compliance. And this actually comes from all walks of life. So whether they are educated or not, sometimes we think that because of poor social cultural background, poor educational level of background. But then again, I see that patient not only from those groups, but I see the educated one and whatnot, we still face some issues with that as well. So I think it must be properly highlighted and stressed. That is actually should be the way that we want to, for them to start treatment with, with the medication and whatnot. And then when do we do surgery? This is when all those modalities of treatment, we don't have any other choice and options, then we should consider doing a surgery in our patient. But then again, this is what I think we should also mention to our patient. When we do surgery, doesn't mean that actually that's the end of it. That means that when after surgery, they don't have to use the medication anymore. That is actually far from the truth. Well, surgery is actually as to help them to obtain good symptomatic relief, as well as to facilitate the use of the medication. Let us look in how that actually the reasoning and the principle of doing surgery in patients with allergic rhinitis. If we look at our nose, this is the cross-sectional section of the nose and also the paranasal sinuses. And most of us probably aware and know that the main airflow will go through this area, which is between the septum and also the inferior turbinate, and it go up and it goes along the this middle metal area, and some of it will go up to actually stimulate the olfactory nerve, and some will go through this area. And anything that actually is causing blockage around here will actually add on to the suffering of the patient. And thus, when we do surgery, actually most of the time is because of nasal obstruction. And in this study that we did in our local population, we noted that actually those patients that has poor control of allergic rhinitis, the predominant symptom is nasal obstruction. And thus, when we do actually surgery, most of the time is actually to get relief of the nasal obstruction. And together with that, when we remove the soft tissues and whatnot of the nose, at the same time also we can get the additional relief of rhinorrhea and also the other symptoms of allergic rhinitis. And if you can see here, despite all those available treatment options that we have, until this day, we still actually have problem and we still have a lot of challenges in terms of treating our patient with allergic rhinitis, even though we say it is quite simple, straightforward. But in real world, actually in real world data, we still actually, acknowledge that there is an issue with us in how we treat our patient, because whatever we do for our patient, if they don't understand, they don't comply, and then they are actually quite confused in what way that the medication can help them and in how they should use the medication. And that is how actually the treatment will fail. And actually, when we actually recommended this, the expert opinion, we actually opined that we should actually categorize the patient according to profiling. In a better way, probably when we profile them, then we can actually rationalize in how we can use the medication properly. And also this also will avoid confusion, especially among the primary care practitioners, where we know that actually they are the frontliners. They are the first line of personnel that we see most patients with allergic rhinitis. So they must play a big role in terms of managing patients with allergic rhinitis. And as I mentioned, when you want to consider surgery, surgery is not the end of all the treatment. It's just an adjunct, something that we can do for our patient to help them actually, and also facilitate the delivery of topical medication. When I say this, is actually what I meant is actually the use of intranasal corticosteroids. Because if there is something in the nose, especially if there's deviated nasal septum, if there is a very big inferior turbinate, that will actually hinder and block the proper use of intranasal corticosteroid. And when that happens, steroid doesn't reach the nasal mucosa. Steroid is blocked from delivering the optimal dosing of steroid. That is where, when our patient use it, they feel that it actually has no benefit at all. So when the patient say there's no benefit, then they don't want to continue using it because they say, oh, why should I use this medication when it doesn't have any effect on me? So if you look at it in terms of that perspective, then I'm sure you agree with me. There is a good role for us, good role of surgery for us to actually advise the patient if the patient has a problem in terms of not responding well to the intranasal corticosteroid. They have moderate to severe symptoms. They have probably poor compliance because of the issues that I mentioned to treatment. And also despite all the good compliance, despite being very, regular use of medication, they still fail the pharmacotherapy. That is where, when we can advise them for surgery, and the surgery is meant to actually help in terms of the medical treatment to works better. And I took this from the International Consensus Statement, ICARV, been actually published 2 years back. The experts from the United States that actually they highlighted the role of surgery in terms of managing patients with allergic rhinitis, and this is what they say, and I actually agree, and I think probably most of you will agree. This is probably the two common surgery that we can consider for our patient with allergic rhinitis. You know that inferior turbinate is always the prime target, is always the common culprit when you talk about nasal obstruction. And we tend to see patients that has allergic rhinitis, they tend to have very big inferior turbinate. And thus when patient has that problem, we can actually advise them to undergo a turbinate reduction. And also septoplasty, as been mentioned by Prof. Aniza. Septoplasty is an anatomical abnormality whereby when patient has it, then whenever they have allergic rhinitis, their symptoms will be more worse than those patients that don't have deviated nasal septums. And thus when this patient has a problem with the deviated nasal septum, I think there is a role for us to actually advocate them to undergo septoplasty. And again, when we are doing all this procedure, we are not actually treating the allergy, because allergy is actually a medical condition. What we are treating is actually, we are treating the anatomical abnormality so that when a patient use the intranasal corticosteroid, then they can use it better. So actually a lot of studies have shown that there is some benefits of doing surgery in this selected group of patients. And I think, again, as I highlighted earlier, most of our patients want to get very good relief from their symptoms. And if you keep on going to treat them with medication and they don't get relief, and that is where when they say actually there's no benefit for them to come and see the doctors because doctors can't do anything much. So if you think that your patient needs surgery, I think it's worthwhile for us to consider these two types of common surgery for them to actually be subjected to. And I don't want to highlight or go further to talk about all this neurectomy, post-nasal neurectomy, but at least you can think about it and consider, because if let's say the turbinate hypertrophy, turbinate reduction surgery and septoplasty have failed, then there is a role of, for this patient to undergo this sort of procedures. But this is probably more of an advanced surgery. The first line is always turbinate reduction surgery and also the septoplasty. So when we talk about turbinate surgery, turbinate reduction surgery is about how we can reduce the size of the inferior turbinate. And you can probably imagine if there is a big turbinate here, there is a deviated nasal septum here, this nose will be actually completely blocked. And that is when the patient will suffer the most, when they can't breathe. And you know that when patient can't breathe, what happens is when they sleep also, they sleep with their mouth open. So mouth breathing. And mouth breathing is not a very good condition to have, because when you mouth breathe, you have a dry throat, you don't sleep well. And thus also you're going to have a lot of problems with sleeping and sleep dysfunction. There are many procedures to choose from. In the literatures, they are mentioned whether it's just a fracture, SMD, this being like traditional choice of methods. But nowadays we have more tools to actually perform this surgery with. We can choose from using a microdebrider. We can choose radiofrequency as well as coblation. You know, when we talk about turbinoplasty, it's not just one type of instrument. It's just not one type of surgery. There are two types actually. Overall, if we want to put it in the proper perspective, is the intraturbinal as well as extraturbinal. Probably in a simplified form, I can say that when we talk about intraturbinal, is that when we do a tunneling method like this, injecting instrument inside the turbinate, and thus we actually induce soft tissue reduction, or we ablate the soft tissue so that it reduces in size. There is this method that when we introduce a radiofrequency, or you can also use some microdebrider, the smaller microdebrider is used purposely for the inferior turbinate. We inject or we use a tunnel, we create an incision, we use a tunneling method from the anterior end until the posterior end. So then we get the utmost relief from the turbinate hypertrophy. And you know, this is one type of procedure that you can do for patient with turbinate hypertrophy. The other procedure that you can do to get to perform turbinate reduction surgery is by doing an extraturbinal turbinoplasty. What this means is actually we actually remove the soft tissue together with bone. And I think that if patient really has very severe nasal obstruction, probably this is the method of choice whereby we remove the soft tissues together with the bone. Because when we do that actually, and studies has shown this, when we perform this type of procedure, patient will get the utmost relief, and also we get a very good space inside their nasal cavity. So as I mentioned, we can use radiofrequencies, we can use coblation, we can use microdebrider, and in fact, actually, we have done a study looking at this using both coblation and microdebrider. They're actually equal in terms of getting the relief from the turbinate hypertrophy in terms of getting good space inside our nasal cavity. And at the moment, if you want to know what is the gold standard of turbinate reduction surgery, actually at the moment there is no gold standard, but from all the reviews that has been done, it has been shown that most of the surgeons prefer to use coblation to prefer to use radiofrequency, prefer to use a macrodebrider. And because of that, in terms of preference, macrodebrider, radiofrequency, and collaboration is actually on top of the list at the moment. Now, going towards a patient that has septal deviation, we actually can subject them to septoplasty. Septoplasty, as you know, is sometimes some patient they may come to you, right, with septal deviation. But if they don't have any nasal block, they don't have any symptom, we can just leave them alone. It's not to say that all patients with septal deviation must be subject to septoplasty, because I know some of my patients, they come with different problem. When we actually subject them to a nasal endoscopy, it's just something like an incidental finding. So those patients, we do need to subject them to the endoscopic septoplasty. But then when you look at this patient, when you have this patient that has this sort of abnormality, this is actually a classification of Malina. I won't go into further details about this, but this is how we classify patients with septal deviation. They are not all the same. There are different types of septal deviation. Some are even worse than the others. And in fact, you can see when patient has very severe deviated nasal septum, what happened is that part of the nose will be completely blocked. And you can imagine if patient on top of the allergic rhinitis, they have a lot of edema, they have a lot of discharge, even though it's mucoid discharge. And on top of that, they also have this problem with their septum. Definitely the nasal symptom will be compounded and will be aggravated. And that's the role of doing septoplasty in those group of patients. And when we do septoplasty, this is one of the common techniques that we use. We create an incision at the mucocutaneous junction of the nasal valve area, and then we go from anterior to posterior. This is the septum, the cartilage septums. This is the mucosa. One of the most feared complications of septoplasty is actually septal perforation. I actually, in my experience, I've never seen anybody that has undergo septoplasty from actually suffering post-operative, septal perforation. But that doesn't mean that it cannot happen. It's one of the most, one of the mentioned complications of doing septoplasty. And actually, care must be taken that you don't remove a lot of the mucosa over this area. And if you injure the other mucosa of the opposite side, that is when you're going to be actually encountering patient with post-septoplasty with septal perforation. But most of the time, we hardly encounter patient that post-septoplasty, they have septal perforation. And those patients that has a very severe deviated nasal septum, not only the cartilage will have to be addressed, but also the bone. This is the bone from the maxillary crest area. So when they have very severe deviated nasal septum, especially when the cartilage and the bone is being dislocated, this is where the airflow goes in. And when there's inflated beneath around here, and if the inflated is engorged or very big in size, and you have this nasal, the bone here, actually compounding the problem with the nasal obstruction, and we don't address this properly, then that is not going to, relieve the patient's symptoms. And that's when we do septoplasty, we have to address this sort of abnormality in those patients. I won't go into the debate whether you should do SMR or whether you should do septoplasty. SMR is when we remove all these structures, and septoplasty is when we actually reconstruct the septum. But it has been said that when you do septoplasty, it has far less complication than when you do SMR. And when we put back the nose, the mucosa, this is where when you see we remove the deviated nasal septum, then you can see the space that you can obtain for the patient to breathe from. And definitely with this kind of space, patient, we really appreciate what you do for them. And I'm going to go further than just talking about allergy alone. I would like to mention to you, because sometimes you may wonder, in some of your patients that you are treating, they also have allergy. So what about those patients? So actually, this was a recent study that we published together with my colleagues from UKM, Prof. Aniza and Professor Salina. We look at patient that has chronic rhinosinusitis, and they also, on top of that, they also have allergy. And you know that this is the subset of patients that actually have both condition. And probably I won't go into the debate about whether it's the causality or whether it's the effects and whatnot. This is probably an association, and also probably this the phenotype subgroup of patient that has chronic rhinosinusitis. And so when you look at patient that has this condition, they have allergy, they have chronic rhinosinusitis, and inside the nose, you know, when those patient has these two conditions, their nose will have a lot of edema. They may have also nasal polyp, and this area, most of the time, the osteomotor complex. This is the minor turbinate, this is the septum, this is the minor turbinate, this is inferior turbinate, this is the septum, and this is the area of the osteomotor complex. This is actually the ammoidal sinuses. This is the mesosinus. And when we actually have this patient, and where the nose is actually really bad, and the symptoms are bad, they don't respond well to the medication that we actually subjected them to. And this is one of the options for us to actually consider doing a functional endoscopic sinus surgery. I just put up some of the part of the procedure that we do for our patient with endoscopic sinus surgery. The first one is uncinectomy. Then we do maxillary enterostomy, and also together with a monectomy. But I hope you appreciate that when we do this, what will happen is this is the minor turbinate, this is the minor turbinate. We actually remove the uncinate here, all right? And when we go and do an monectomy, we remove the structures here. And in fact, not only in patient with chronic rhinosinusitis, but also patient that has obstructive sleep apnea, this procedure has been proven to show very good relief for them, because I hope you can appreciate what when we do these procedures, we remove these structures, and what happened is there'll be more space for the patient to breathe. And thus with that principle, the patient will get the maximal benefit of after undergoing this procedure. So my closing argument for this evening is that you should consider endoscopic nasal surgery if when the patient don't respond well to medical treatment. But always we must highlight to the patient, it's not the end of everything. That doesn't mean that when you actually go for this type of surgery, then you don't have to use medication. It's just for them to actually use the medication better, and also it helps them to actually facilitate the delivery of the medication. Because if patient have very big turbinate, patient has deviated nasal septum, when they use intranasal corticosteroid, the steroid sprays won't go to their target area where we want them to get the maximal effects. And thus when that happens, patient will not get the maximal benefit of using the intranasal corticosteroid. And just a lot of studies have shown that when actually we do these procedures in patient, it actually improves their quality of life. And at the end of the day, what we want to do is actually to get the maximal benefit for our patient. With that, ladies and gentlemen, thank you very much.
Thank you. Thank you very much, Prof. Baha, for such an enlightening talk. You may unshare your slide.
Yeah, sorry.
Thank you.
Okay.
Thank you very much. Okay, we are go to the second part of the session today, which is a question and answer. Thank you to Prof. Aniza. You already answered a few questions, by typing in the Q&A. And I know there's a few questions we need to answer. But before that, there's a question by our good friend from Sabah, Datuk Dr. Patawari. He already emailed to us earlier, I think, Mr. Lam, a few days before, right? So Datuk Patawari, we're going to answer a few of the questions. I think the question number one is, the question can be answered by any of the panelists, but probably the first question I give to Prof. Aniza first. What is the role of oral steroid in the management of severe allergic rhinitis?
Okay, thank you, Prof. Yes, that is indeed a very good question. For adults, there is a role of oral steroids in severe allergic rhinitis. So you can give them about 1 week of steroid to help reduce the inflammation, and then get them to continue using their intranasal steroids. It's just now we are in a COVID pandemic, so I do not recommend using that particular route for these current times. And I stress again that it is only for adults, not for kids.
Do you have any regime for the steroids given?
You can give low dose steroids, about 20 milligram per kg for about 1 week. You don't need to taper. That should work.
Great. The second question, again from Datuk Patawari, this time I give to Prof. Baha. He was asking about the role of surgery in children with a severe allergic rhinitis with a nasal blockage. If there's any surgery, what surgery do you recommend for this age group? Prof. Baha.
Well, thank you, Prof. Razif, and thank you for the question. It's always a very interesting question, especially when we are dealing with children. And you know, children, we always want to have this kind of strategy of hands off, not doing anything, because we are always scared about complication. But on the other side of the coin, you should consider if you don't do and patient suffers the very bad quality of life. And as I mentioned, the problem with allergic rhinitis is the complication. It has been shown that I was mentioning about mouth breathing just now. It has been shown that when children with allergic rhinitis, they're not been treated properly. What happened is they're going to mouth breathe. And when they grow up, they have problem with the mandible, they have problem with the maxilla. And when that happens, they're going to suffer probably permanent obstructive sleep apnea. I'm not talking about my own experience that has been shown from a lot of studies and literatures mentioning this. And thus, if we want to actually, talk about discussing proper management of children, we should actually use all the available options for us. Besides not having to do anything, hands-off approach, medication fail, you assess the patient, they don't respond well, think about surgery. So even though I mentioned surgery, you don't have to go straight away to the radical surgery because most of the patients that has allergic rhinitis, children with allergic rhinitis, they also have adenoiditis, they have adenoid hypertrophy, and just by doing probably an adenoidectomy, that will help the patient. So we go like step-wise method. We go first line, probably we can subject them to adenoidectomy. And with the adenoidectomy, most of the time it's because of the nasal block, right? So when via adenoidectomy, they get very good relief from then, and then they can continue using their medication. And when we want to talk a little bit more radical surgery, I would probably, a bit controversial, should you do a septoplasty in patient, in children? Big debate, big controversies, but I see some literatures now saying that children with this sort of issues and problem, when we subject them to septoplasty, they have better quality of life for the reason that I mentioned just now. And also probably if you want to consider doing turbinate reduction surgery, you can do actually the intraturbinoplasty. As I mentioned, intraturbinoplasty is just an injection method whereby there won't be hardly any tissue damage and also damage to the surrounding area. And I would say that perfectly safe in children if they require this sort of process to be done.
Thank you, Prof. Baha, for the answer. Do you have any age limit? Usually people will ask, because you can answer the next question as well. Always in pediatric, two questions come up. Number one is, what is the safe intranasal steroid in the pediatric age group, and what age usually you can safely give the patient? That's number one. And again, number two, the question about surgery. Do you have any age limit, before you think of doing any surgery for this patient? Prof. Baha.
When we talk about age limit, actually, there is no such age limit. But if you look at the, the algorithm, the protocol and whatnot, in terms of using intranasal corticosteroid and also the oral antihistamine, it's always been mentioned about 2 years and above. All right. You know why this the recommendation is such as that? Because no studies has been done in children less than that. And also it makes sense that, children and allergic rhinitis, when they are quite small, probably they don't suffer, they don't go out and whatnot. They don't have much of a problem with the nose. Most of the time they say children tend to have allergic rhinitis when they go out. The school, toddlers age group as mentioned, they go out, they are exposed to all those allergens, then that's when they start to have problem. So then it makes sense and logical for us to think that probably these children, you're not going to subject them to any radical procedures and whatnot. You just to start them on, most of the time they actually can probably get relief from just doing sinus ring, nasal irrigation. That's probably just good enough. We can remove the secretion. You can remove the inflammatory mediators as mentioned by Prof. Aniza. They can get a lot of relief by just doing that alone. And if the patient require more than that, can subject them to the non-sedating oral antihistamine as well as the intranasal corticosteroid. And in fact, there is hardly any adverse effect when you use intranasal corticosteroids in children. Studies so far has shown no adverse effect at all, except for one study that shown if you use it for about a year in children continuously, there might be some issues with the growth retardation.
Okay, thank you, Prof. Baha. Before I move to the next questions about the immunotherapy, again, two questions usually frequently asked. Number one is we discussed just now about pediatric. Number two, in pregnancy. Maybe either you or Prof. Aniza can entertain this answer. What do you do if patient, a pregnant lady, of course, lady and pregnant, not men, how to treat allergic rhinitis in pregnancy? So maybe Aniza.
Human issue we give to the woman.
Yeah, true.
Okay, so when you see a pregnant lady who complains of rhinitis symptoms, you need to ask them, did they have allergic rhinitis prior to being pregnant, or did this only start after they were pregnant? Because this means that it's different pathology. If it only started after they were pregnant, meaning before pregnancy they were perfectly fine, it is most likely hormonal induced rhinitis, and this is not allergic rhinitis. It is a type of non-allergic rhinitis due to the hormones in this lady's body. Not much can be done for them. You can try intranasal steroid. Nasonex is pretty safe for pregnant ladies, and I know that the only drug that is class B for pregnancy is the budesonide nasal spray Rhinocort. And that's relatively cheap, but that one actually has systemic absorption. It's just that Nasonex is rather new, but it has been reported more and more that it's actually safe in pregnancy. But the bad news is that if it is really hormonal rhinitis, they will not respond very well. And you should also add some nasal rinses for them, because these nasal salines, they actually give them some symptom relief. But at the end of the day, you just tell them your problem will be solved once you deliver. Okay, for patients who have had they've already had allergic rhinitis, and then when they get pregnant, this rhinitis symptoms gets worse. So they should continue their intranasal steroids. I usually tell them to only start after the second trimester, because although the study says it's okay, I really don't know. I do not want to risk it. I just tell them, try antihistamine first, and then in the second semester they should be quite safe. Second and third trimester they can restart their intranasal steroid to help control the nasal symptoms.
Great.
That answers the question.
Yeah, Prabha, you want to add anything on that? Or
Yeah, I actually always sympathize with my women comrades, with the ladies that have this problem, because sometimes when they have these issues, it's very bad. They have no other alternative, and so when they say that, what are the options? We have to consider whether we want to treat them or not, because if you don't treat them well, they really suffer. They hardly can breathe at all, whether they have allergic rhinitis together with pregnancy, or whether they have pregnancy-induced rhinitis. So when we treat them, it's always weighing the risk and benefit, whether you can give them more benefit than the risk. The risk is always on the baby, right? But actually, studies so far has not shown any adverse effects to the baby. It's just that there has no studies been done in pregnant women, so that we don't know what the effect is like. But so far, in terms of animal studies with this medication, even with oral antihistamine, has shown no teratogenic effects on the fetus. And so actually, probably the right way, I agree with what Anissa mentioned just now, start then on saline irrigation. And then when we want to go to the pharmacotherapy, advise them this when they use it as actually at own risk kind of approach, because you read the fine print of the medication that you use, they never say that if you want to use it outside their recommendation, is kind of at kind of own risk kind of basis. They're not going to, be responsible for any problem if the patient has problem later on with the use of the medication. I think what has been mentioned by Prof. Anisa is intranasal corticosteroid. I think that actually probably the best approach for us to start the patient on any pharmacotherapy, because there's hardly any systemic absorption. The current intranasal corticosteroid that we use has no systemic absorption. It's just the local effects. I would say that's quite safe to be used in all the 3 semesters in pregnant women. We always are more careful if the pregnant lady is in the first trimester, because that is where the agonogenesis is actually happening. We try to avoid any use of systemic medication, especially the oral antihistamine in that first trimester. And then from there on, probably it's quite relatively safe to, I would say, to start them on pharmacotherapy.
Thank you, Prof. Bahar, because there's a few questions asking about this. So I think I suppose to cap on that, first trimester, maybe we just treat as conservative as possible because of development of the fetus. Second trimester onwards, we can consider pharmacotherapy. So we move to immunotherapy before I forget about this question, because there's a few questions in the chat box, and even Dr. Patawari also asking about the immunotherapy. So if you can comment on 2 issues of immunotherapy. Number 1, is there any center in Malaysia that perform this immunotherapy? And just a few words of this, how this immunotherapy works. Maybe Anisa can, is it okay?
Yeah? Yes, we do have immunotherapy in Malaysia now. We have sublingual immunotherapy in UKM. We have it in tablet form, which is the Acarizax, and there's also another one which is you drop onto your tongue. But we only have the preparation for dust mite. But it's okay because that's what's mostly our patients are allergic to. The idea of giving immunotherapy is that you want to modulate the immune system. You want them to develop tolerance. They will need to build up an immune response to the immunotherapy, and then immunologically, they will then start to develop these what we call blocking antibodies, which will sort of prevent the allergen from causing symptoms in your body. But you have to take it for 3 years, because studies have found that if they give it only for 2 years, they tried it for 2 years. Unfortunately, the long-lasting effect is just not as good as if you give it for 3 years or more. The issue with immunotherapy is that it's not being covered by GPA at the moment. We can only get it in if you're doing it for research. Patients have to pay, and it is a lot of money. 700 ringgit for 3 months for the drop type, or 450 ringgit for the tablet type per month for 3 years. A lot of us can't afford that. So that is a problem.
Yep. Thank you, Prof. Anisa. We can discuss this sublingual immunotherapy today, because yesterday we can't, because this is a question that people like Dr. Sarniza, Dr. Sarah, and a few others, for other people who's watching this is a exam question. Prof. Zul, Prof. Bahar, this is a immunotherapy. So they think they answer well, but they're not. So, but they pass lah. Okay. The next that we can discuss is, I made a few questions again about this. Questions, Prof. Bahar, is patient coexist of allergic rhinitis and nasal polyposis. How do you go about treating this patient?
Sorry, what's the question again?
Patient with allergic rhinitis patient, they also have nasal polyposis. So how do you treat this patient? You do the surgery first, or you treat the allergic components first with steroid? How basically you managing this patient?
Actually, Prof. Razif, I think it's a very good question. That's why from the beginning, my statement is, even though I actually talk about surgery, it's not that I'm trying to advocate surgery for all patients. As I mentioned, this is the sort of things that you should consider. Let's say later on the medication fail. So actually it should be taken in terms of that kind of approach, rather than you always think about surgery as the first line. And whether patient has allergic rhinitis or whether they have nasal polyp, and probably I would say that patient is actually having rhinosinusitis or chronic rhinosinusitis. Both of these conditions are medical conditions. They cannot be cured by surgery. I think we have to actually keep that in mind. What we are doing is actually, when we do surgery, is actually for them to respond better to their medication, and especially to intranasal corticosteroid. And so when patient has both allergy, they also have nasal polyp, the same line of approach should be actually adopted. We should use the same line of approach. We use maximal medical therapy should be the key terms. Don't forget that actually we don't actually maximize our medical treatment, and that's when patient don't get the maximum benefit. If the patient use probably just 1 puff daily, we can increase the dosage to 2 puff daily, and even some we can even use 2 puff BD to maximize the intranasal corticosteroid. And in fact, patient that has nasal polyp, the recommendation for intranasal corticosteroid is actually 2 puff twice a day. So then they can get the most maximal relief of the steroid to actually decongest the nose and also reduce the size of the nasal polyp. A lot of studies has been done that shows that if you use maximal medical therapy, they actually will respond to this medication, and it takes some time for them actually to respond to that. So you have to allow some time for them to use the medication. In some patients that fail those topical, you can subject them to systemic, like Adizam mentioned. We can use about 20 milligram a day up to 2 weeks. Most of them we respond to that, and only when they fail, those maximum medical therapy, then we can subject them to surgery. And most of the time when patient has a polyp, we subject them to an endoscopic sinus surgery.
Thank you very much, Prof. Baha. Maybe last question before we end. I think there's a very interesting question about allergic rhinitis and eustachian tube. I think that's one of the questions, quite nice about. Yeah. So Aniza, do you want to comment on that?
Yeah, well, eustachian tube dysfunction from allergic rhinitis is thought to be due to the, if there is edema in inflammation in your nasal cavity, that edema can also happen in your eustachian tube opening. So the treatment should be targeted at treating the underlying cause, which is your allergic rhinitis. Now, I know some patients may fail this, even after giving steroids and nasal decongestants, oral decongestants, they may still get this eustachian tube dysfunction, and you can see it from, it is affecting their middle ear, where there may be retraction or there may be middle ear effusion. You just have to treat that as it comes. I think Ms. Dina was talking about eustachian tube dilatation in children now may help these children with eustachian tube dysfunction, but I'm not an expert on that topic. Okay.
How you have to comment anything on this?
Yeah, actually, very interesting. I have some patient that has allergic rhinitis, sinusitis, that also present with eustachian tube dysfunction. I think probably why we are not aware of it, because we don't assess our patient properly. We don't ask the right question, I believe. That's how probably is, I believe it is underreported and underestimated. Probably the prevalence is more than that. As I mentioned, that patient that has allergic rhinitis, they also have other problems as well. And one of them is eustachian tube dysfunction. In our patient, especially even adults that has allergic rhinitis, they also have adenoids, adenoiditis, and also adenoid hypertrophy. And I think similar mechanism is actually involved in that. When patient has a lot of inflammation inside the nose, the postnasal space, the nasopharynx also will be affected. And those inflammatory mediators, they don't have any immigration control. There's no border control. They can go anywhere. They can go even to the eustachian tube. And if the eustachian tube is inflamed, this will cause eustachian tube dysfunction or even blockage. What can we do actually for patient that eustachian tube dysfunction is the normal procedure that we do. If patient has middle ear effusion, we can subject them to meningotomy and also grome. And also, I actually have done a few procedures that I do with balloon dilatation. And actually, it works very well. You can insert balloon, the balloon sinuplasty that you use for endoscopic sinus surgery. You can insert that, and actually it's quite safe because eustachian tube is actually quite resilient, quite tough. You dilate it properly using the proper procedures. you're not going to injure any structures there. And most of the time we are scared of the internal carotid artery, because internal carotid artery is just behind the incision tube at the junction of the bone and also the cartilage. It's just behind there. But actually, even internal carotid artery actually is quite tough as well. I don't see any report of patient having problem with the internal carotid artery after undergoing balloon tabuloplasty. And I think probably you should consider that. Thank you.
Thank you. Thank you very much, Prof. Baha. I think Dr. Lam, we are at 7 o'clock already. I think we can wrap up. I think there's a lot of questions and already being addressed by our two speakers. Again, before I pass the mic back to Dr. Lam, I would like to say thank you very much to Prof. Baha and Prof. Aniza, not just for your brilliant lecture, but also answer a lot of questions. And before we end, maybe we give ladies first, Prof. Baha, to Prof. Aniza. Do you have any take-home message that we can give to the audience? Like I mentioned, we have from medical student, our medical officer, our friends from general practice, our ENT surgeons from public and private, and also, our maxillofacial friend there. I don't know whether Hazmi later on treat allergic rhinitis, but So Aniza.
Okay, so I'd just like to say that when dealing with patients with allergic rhinitis, this is a common condition. Definitely you need to look for all those allergic characteristics to be more confident that you are truly dealing with allergy. But I think the most important thing about managing allergic rhinitis is that managing patient expectations and really talking to them, because this is sort of like a lifelong disease that they will have to deal with. So I know some of you may get disheartened by some patients who seems to have uncontrolled rhinitis, but I think if you really talk to them and explore your options, you can get these symptoms under control, and you can always refer them to us for further workup and assessment.
Thank you, Prof. Aniza. Well said. Prof. Baha, any last words?
Yeah, Prof. Razif, allergic rhinitis sometimes we tend to take for granted, we take it lightly because we say that it's not fatal, it's not life-threatening, but don't forget that the patient really suffer. We don't treat them properly. They're not going to be, having very good quality of life. So bear that in mind. And I think it's our responsibility to actually advise them on what sort of, measures they can take for them to manage their condition. I think the proper approach should be, informed to them, so then they have a choice on what kind of medication they can choose from. A lot of times the confusion is because they don't know what should they do and what sort of medication that they should be taking, and the mainstay is always oral antihistamine together with intranasal corticosteroid. And most of the time, if they really are complying with that, they actually will get the most benefit from that. Most of the time, what I face is actually when they have poor compliance. And when they have poor compliance, that is when we have a lot of issues, the complication as well. Don't forget, patient with allergic rhinitis is not only the symptom, it's also the complication. We mentioned one of them is suction tube dysfunction. Don't forget about sleep dysfunction, sleep disordered breathing. Some of our patients tend to have that problem as well. We don't treat them properly. This is what they're going to be, facing. And I think it's not, justified when we have all sorts of modalities nowadays for us not to actually subject them and administer the proper medication to them. Thank you.
Thank you very much, Prof. Baha. Thank you very much. Thank you very much, the speakers. So before I pass back to Dr. Lam, again, thank you from organizing committee. Thank you for both your lecture, and again to all the participants. Thank you very much for your support, and big thank to Mylan, who in this product Dimistar, we use Dimistar. Thank you for your support, and Dr. Lam, I pass back to you for the closing remarks. Thank you.
Thank you, Prof. Razif. Again, thank you to the speakers, Professor Baharudin and Prof. Aniza, for making this webinar session very informative and interesting. I believe everyone has learned something new this evening. And again, allergic rhinitis is very common, and we always thought that we knew everything about it. And actually, there's so much more that we need to learn about it, especially regarding the pathophysiology and immunology. So before we end, we'd like to take this opportunity to thank again Prof. Salina and all the lecturers and staff of the Department of Otorhinolaryngology of UKM Medical Center for their support for this webinar. And thank you for all participants for taking part in this event. And again, thank you to the sponsor of the event, Mylan Healthcare. And before we end, I will display the QR code again. You get 1 point for this for attending this webinar. For your information, we applied 2 points, but only 1 was approved by the council. So thank you everyone and for spending your time with us this evening, and have a good night. Bye-bye.
Thank you, bye.
You can take a photo, Lam, Karan.
Kejap Pro, nanti I leave it for 1 minute, the QR code. Lepas tu I
Okay. Can leave a few minutes, all right. We can wait, yeah. We don't have flight to catch lah. Thank you, Lam, for your nice organizing correct. Thank you.
Thank you. Thank you, everyone.
I think should be okay, got Lam.
Yep, I will unshare the slide. If you can have Prof. Aniza back with us for a photo session. Yep.
Right.
Okay, 1, 2, 3. Kejap, one more time. Kejap. I make it a full view. Okay, 1, 2. Freestyle.
Oh, Krista.
Jump.
Okay.
Okay. Thank you, Lam. Thank you,
Okay,
Probaha. Thank you, Aniza.
Thank you.
you,
Enjoy.
Prof.
I
Thank you
enjoy.
very
Thank you so much.
Thank you, Lau. Yep.
Thank you, everyone. Okay, bye-bye. Good night.
Bye. Take care. Good night.
Nah.